faculty of OBG RMC and dear postgraduates. At the outset, I thank the OBG department of RMC for giving me an opportunity to continue the further proceedings of our gestational diabetes. So the last two classes, we have discussed something about the GDM. And this class is very, very important for the simple reason that the total management of the GDM, we are going to cover it in the next few minutes. See, appreciate the importance of the pre-pregnancy counseling in the pre-existing diabetes and pre-diabetes. Discuss the therapeutic options for the diabetes in pregnancy. So the pre-pregnancy counseling is equally important for all the pre-diabetic individuals and also the pre-existing diabetes individuals. What are all the consequences they are going to face it? See, it is an index case about 38-year-old obese lady with type 2 diabetes presents to your office for follow-up visit. Her blood sugars has been well controlled on the metformin. She wants to have a baby and wants to know if there is any special thing to do so that her diabetes will not affect her pregnancy. So would you advise her? What would you do regarding her anti-diabetic medications? So this includes your pre-pregnancy counseling. So aged about 38 years and she is also obese. It's a type 2 diabetes. Now wants to conceive. And another case, a 28-year-old female known to have the type 1 diabetes for the past 14 years. So she got the type 1 diabetes at the age of 14 years. Now she is 28 years old. Comes for the pre-pregnancy counseling. So what relevant history would you like to elicit? What examination and investigations would you do? And how would you counsel? So educate and obtain the maximum cooperation from both the partners. That's very, very important in the pre-pregnancy counseling. Obtain the optimum diabetic control before the conception. So you know that HbA1c, the diabetic HbA1c is 6.5 and the normal HbA1c is 5.7. So somewhere between 5.8 to 6.4 is the pre-diabetic. So the fasting blood sugar less than the 100 and the postprandial blood sugar around 140. So that is your optimum diabetes control. Emphasize the need for the strict diabetes control to prevent the maternal and the fetal implications. Check for the thyroid function also in all the diabetic individuals. So don't be happy with the TSH alone. So get the free T3, free T4. And the TSH is somewhere between 5 and 10 if you are suspecting the subclinical hypothyroidism. So better to get the antibodies also, TPO antibodies. Once the TPO antibodies are positive, even at the TSH of 5 or the 4.5, you are supposed to treat with the thyroxine medications. Check the immune status against the rubella and other viral diseases. And there should be a multidisciplinary approach between a good coordination between the obstetrician, with the physician or the endocrinologist or diabetologist, nutritionist and educator. See, understanding the risks. So what about the congenital anomalies in the pre-pregnancy diabetes? And what about the perinatal mortality? Diabetic complications in the pregnancy, whether it's a diabetic nephropathy or a diabetic retinopathy or the neuropathy or vasculopathy. And what are all the obstetric implications and inheritance of the diabetes in the offspring? Because treating a diabetes in the pregnancy, so you are treating the diabetes in 2 generations. What a diabetic pregnancy involves, the frequent antenatal visits and the close supervision. So it's very, very important is the follow-up and the regular antenatal visits and strict blood glucose control, your self monitoring of the blood glucose, SMBs is very important, the glucometer is very important. So the need to check the blood sugars, fasting, at the pre-lunch, at the pre-dinner, or at the time of the bedtime, sometimes at the 3 a.m. or the 4 a.m. to rule out the Somogy phenomenon also. And of course, the good diet and the lifestyle modifications are very, very important. So what is her weight at the time of the conception? What is the weight gain during the pregnancy? So what about these? All the things are very important to decide. So how much amount of the carbohydrate or the fat or the protein you are supposed to advise. And folic acid supplement, big thanks to our Yallapragad Subbarao garu, who invented the folic acid, a very beautiful vitamin to reduce the congenital malformations, the must for all the antenatal visits. And of course, the contraception till the optimal glycemic control. So once the HbA1c prior to the convention, so if it is a 9 or the 10, So you should not allow her to go for the pregnancy. So because so they have to reach the HbA1c target of 5.7 or less than the 6 is the ideal. So till then we have to give a good contraceptive measures. These are very, very important, and low dose of the aspirin in selected cases. Sometimes you are suspecting some vasculitis, etc. So definitely there is a role of the aspirin in such individuals. See, organogenesis occurs much early in the first trimester itself. So before the woman reports to the antenatal clinic that, so before the woman knows that she is pregnant, so almost a lot of the organogenesis has done occur. So that is the reason all the congenital malformations are very, very common in the pre-gestational diabetes rather than the gestational diabetes. So gestational diabetes means the second half of the pregnancy. So they pass on these congenital malformations in the true gestational diabetes, whereas in the pre-gestational diabetes, they are more prone for the congenital malformations. So uncontrolled diabetes during this stage increase the risk of the major congenital malformation, like your spina bifida or neural tubal defects, or VSD, or the ASD, or respiratory gestational syndromes, etc. So these are the very, very common during the pre-gestational diabetes in the first 3 months of the period. So in the first trimester, you will have the congenital malformations and the early IUGR. In the second trimester, the macrosomia, CNS developmental delay. In the third trimester, you have the chronic hypoxemia, stillbirths, and IUD. In the newborn, these people will have the respiratory distress syndrome, hypoglycemia, hypocalcemia, thrombocytopenia, polycythemia, hyperbilirubinemia, usually in the second week or the third week. So immediately you will have the hypoglycemia and hypocalcemia, and the renal vein thrombosis, myocardial dysfunction at a later. So child and the adult, you will have the birth injury because of the macrogemia, high birth weight, behavioral deficits, intellectual deficits, and obesity and the diabetes at a later time as a part and parcel of the metabolic syndrome for both the mother as well as the offspring born to the diabetic mother. The preconception care includes the achievement of the optimal glycemic control prior to the conception is the goal. So you need to reach the HbA1c target of the 6 and fasting blood sugar around 100, maybe 90 to 110. Postpartum blood sugar around 140, maybe 120 to 150. So this must be your goal to reach to have a very good final output without any congenital malformations, etc. If the patient is on the OAD, it is ideal to switch out the insulin if pregnancy is planned, because the only OADs which are preferable in the pregnancy are the metformin. Suppose if the patient is on the sulfonylurea other than the glibenclamide, or if the person is on pioglitazone, or if the person is on the gliptins, or if the person is on SGLT inhibitors, we have to stop all these OHs. Suppose if it is a early onset type 2 diabetes getting lot of the OHs. So stop all the OAD. So continue the metformin, and then they add the insulin for the proper control of the diabetes. Control of the hypertension, because this hypertension is also very commonly involved in the type 1 diabetes and the type 2 diabetes. And hypertensives who use a lot of the ACE and ARBs are the drugs of the choice. But unfortunately, during the pregnancy, we should stop using the ACE and ARBs. So ideal antihypertensive medications are your labetalol, or your alpha methyl dopa, or your beta blockers, or your calcium channel blockers. So the diuretics and ACE and ARBs are strictly contraindicated during the pregnancy. Dilated retinal examination, so to rule out your retinopathy. Suppose if the person is having the proliferative diabetic retinopathy, so should not give the consent for the pregnancy. So pregnancy has to be stopped. So provided if the person is having the proliferative diabetic retinopathy, otherwise these people will develop the retinal detachment, iridocyclitis, etc. during the pregnancy, and there may be the loss of the vision also. So when the fellow is under non-proliferative diabetic retinopathy, control the diabetes, and then you can continue the pregnancy also. Estimation of the renal function. Once the creatinine level is 3 or 4 or 5 before the pregnancy, so definitely termination of the pregnancy is needed. Otherwise, if the person is having the proteinuria, maybe 1 plus or the 2 plus or 3 plus, you have to assess the amount of the proteinuria, 24 hours urine protein, and then act accordingly. Statins, they are very much contraindicated during the pregnancy. So what are all the diabetic drugs which are contraindicated during the pregnancy? Are all OHS except the metformin. Then the ACE inhibitors, ARBs, diuretics, statins. These are the very common drugs we prescribe during the diabetic individuals, provided if they are the early onset type 2 diabetes or type 1 diabetes of the longer duration. So potential contraindications to the pregnancy in the diabetes. This is ischemic heart disease. A coronary event in the last 6 months and ejection fraction is less than the 50%. So no green signal to the pregnancy. So termination of the pregnancy or no to the pregnancy. Advanced untreated proliferative diabetic retinopathy. So already this point I already told you. The same with the renal insufficiency when the GFR is less than the 60. And severe gastroparesis. See the diabetic gastroparesis. So these people will have the lot of the nausea, vomiting, abdominal bloating. There will be the loss of the appetite. So they may not gain the weight because of the severe gastroparesis. And without the weight gain, so the baby health will be deteriorated. So these are all the very, very important not to have the pregnancy, provided if the people are having a lot of the gastrointestinal gastroparesis. Uncontrolled diabetes with HbA1c more than the 10, you are inviting more and more acute complications like diabetic ketoacidosis and urinary tract infections, respiratory tract infections, abdominal infections, pneumonia, sepsis. So these are very common once the failures HbA1c is beyond the 10. So you're inviting the both acute complications and also the infections. So again, a big no to the pregnancy. So these are the contraindications for the pregnancy in a non-diabetic individuals. Now the need for the treating the gestational diabetes. So what are the implications in the mother? So there is increased risk of preterm labor. There is increased risk of the preeclampsia. So the operative delivery, most of these people are go for the sections, and they are the future type 2 diabetics. You all know that GDM is a big risk factor for the future diabetes. As far as the infant is concerned, their stillbirth is common. Macrosomia, the increased likelihood of the birth trauma. So hypoglycemia is a very common. Hyperbilirubinemia, hypercalcemia, hypomagnesemia. So all these things already I discussed about in the last class. So what is the cause for the hypoglycemia? What is the cause for your polycythemia? These are all the hypoxia. So the effective treatment of the gestational diabetes reduces the fetal mortality to the same level as that in the non-diabetic pregnant woman. So this class will definitely help you to reduce the blood sugars in all your GDM or the pre-gestational diabetes to a normal level, so that the outcome is the very, very happy if you compare it as happy as the non-diabetic pregnant woman. So that is the ultimate goal of this class. How you manage the GDM? See again, not the insulin, not the OHA. These two are at the back seat, and the most important one is the medical nutrition and the exercise. These two are very important. Even the GDM or the pre-gestational diabetes, you have to pay a lot of attention on the dietary approach and the exercise. And of course, sometimes you can use the metformin, sometimes you can use the glibenclamide as the OHS, and then of course the insulin is the drug of the choice in all the diabetic individuals during the pregnancy. On the record, off the record. Here another case about the 26-year-old primate detected to have the GDM during the 27th week of the gestation. Her fasting and the postprandial 87 and 182 respectively. So fasting is 87, postprandial is 182. She is 158 centimeters tall and weighs 91 kgs. So she is obese. So ideal body weight is 158 minus 100. So 58 plus or minus 2. Maybe 60 and 62 is the ideal weight, but now the 91. So 30 kg is excess. She is a vegetarian. She follows a sedentary lifestyle, but tries to go for a walk for 15 minutes every day. So still trying. What advice would you give her regarding the diet and exercise? So here a lot to be done. So about your diet and exercise, because she is obese. So nearly 25 kg is excess body weight. So unless you concentrate on the carbohydrate, so less complex, simple carbohydrates, more and more complex carbohydrates, more protein and less saturated fat, less trans fats, more fiber, more fruits, etc. will definitely help her to reduce the body weight along with your exercise, along with your physical activity. So not 30 minutes per day, 5 days a week, unlike the Westerns. So you have to go for the 60 minutes a day, maybe more than the 90 minutes, maybe the 180 minutes, 120 minutes a day, at least 7 by 7. So because we are having more and more insulin resistance, so the physical activity will improve the entry of the glucose into the muscle, entry of the glucose into the liver, entry of the glucose into the adipose tissue, so that it increases your insulin sensitivity. So the weight gain will not be there, provided if the patient is on good dietary approach and good exercise. So a lot to be done in this patient regarding the role of the diet and the exercise. And of course, you have to use the metformin, because all the obese individuals will have a lot of insulin resistance. So as this is a case of gestational diabetes, So in the second half of the pregnancy, so there is no congenital malformations. So better to use the metformin also to tackle the insulin resistance. Still the blood sugar is very high. So without even on the maximum doses of your metformin, tolerate dose of metformin, then you can go for the insulin. Maybe the rapid insulin, maybe 4 units or the 5 units, one shot before the lunch. Because already the fasting is normal here. 87 is the normal fasting. But the only abnormality is the postprandial 180. So with your dietary approach, with your exercise and with your metformin, you can reach your target of 120. But if not, you can add a regular insulin like your human insulin or your analog insulins like Lispro, maybe 4 to 5 units or the 6 units to reach your target postprandial blood sugar of 120. Okay, that's how you have to treat this patient. So the diet is a big role here. Exercise is a big role here. Metformin has a big role here. And then you can go for the regular insulin. I don't think that she requires insulin. This patient definitely feels better with your dietary approach and exercise and the metformin. See, the medical nutrition therapy, MNT is the cornerstone of your gestational diabetes management. Some women with CDM will be able to manage their glucose levels effectively with MNT alone, without your metformin, without your insulin. Maybe 20%, maybe 30%. So, or up to 40% of the GDM population can be managed with a good dietary approach and exercise. What is the aims of MNT? Fulfill the minimum pregnancy nutritional recommendations for the pregnancy. You have to maintain the nutritional recommendations. Otherwise, the fetus is at loss. Achieve the glycemic goals without the weight loss or undo the weight gain. Avoid the ketosis or ketonuria from the caloric restriction and the starvation, because the more the starvation, again the starvation ketosis will be there. So what happens when the fellow is on more and more starvation? So definitely a risk factor for your acidosis. So these are all the recommended weights. You all know that underweight means less than 18. Ideal body weight is 18 to 23. Overweight is 24 to 25, or obese is 25 to 30. So these are very, very common. So the diet, your calories, carbohydrates, fat, protein, fiber. Attain the recommended weight gain in the pregnancy. So you know, there should be a weight gain of nearly 8 to 12 kgs during the pregnancy. Respect your ketosis and IUGR. Ensure the euglycemia. That's very, very important. Successful outcome of the pregnancy. And then the fetal morbidity has to be reduced. So this is the MNT, your protein, your visible fat, vitamin A, folic acid, calcium, iron, vitamin B12. These are very, very important in the daily intakes are also there. So general principles, the meal plan should be tailor-made and easy to understand and follow. Otherwise, whatever the advice you give it, so they don't listen and they don't follow it. So these are very, very important. A small and frequent meals, once in 2 to 3 hours, are ideal to avoid the hypoglycemia, avoid the prolonged fasting. Bedtime snack is advisable to prevent the development of the ketosis at the night because of the starvation. Ensure the adequate hydration. This is also equally important, about 8 to 10 glasses of the water per day, and avoid the fruit juices which contains more fructose and the glucose. Artificial sweeteners, so we use the sucralose, but the saccharin and the glycamine are the contraindicated. Physical activity is very, very important. Already I told you, the complements the dietary recommendations. Activities that increase the blood pressure should be avoided, like lifting the heavy weights, pushing heavy objects, etc. Upper body resistance training. And if the physical activity is restricted by the obstetrician, then the patient should be adhered to his advice. So is another case, female, 28 years, second gravida, undergoes the OGTT with 100 grams of the glucose at 24 weeks of the gestation. So the fasting is 138, 1 hour 259, second hour 217, and third hour 198. So what treatment would you advise? Your diet, your exercise, your metformin, or excellent answer. Insulin. Here the insulin is the answer because all the 4 values are abnormal. Your fasting blood sugar is very high, 138. Your 1 hour blood sugar is more than the 250, second hour 200. With any amount of your dietary approach, with any amount of your physical activity, with any dose of your metformin, the blood sugar control to your target of 90 and 120 is not possible without the introduction of the insulin. So the amount of the insulin is very much needed here to control your hyperglycemia. Diet and exercise, yes, need it. Metformin, yes, because they already in the second week of the second half of the pregnancy. So you can continue the metformin to tackle your insulin resistance. But insulin is very much needed. So this patient needs dietary approach, exercise approach, metformin, plus and plus and plus insulin. So insulin is essential if the MNT fails to achieve the euglycemia by 2 weeks. If the fasting glucose more than the 95, you consider it as the 90, or the 2-hour blood sugar is more than the 120. So your target of fasting is 90 and postprandial is 120. Even after the 2 weeks or 15 days of your MNT, if the values are like this, so definitely there is role of pharmacotherapy. So consider the insulin therapy at the time of the diagnosis if the glucose levels are very high, as the previous case. So here, at the time of the diagnosis, the sugars are very, very high. So straight away you switch over to the insulin therapy. So these are the targets. What about the insulin options? What are all the options you have it? One is the regular human insulin, what you prescribe in your daily hospital, general hospital. Maybe you have the regular insulin, insulin N, insulin R, insulin R, insulin R, your actropit, etc. These are the regular human insulin. So these you have the onset of the action, peak action, and duration. These three you should remember. So onset of the action, peak action, and the duration of the action. See, if you take the regular human insulin, so onset of the action about 30 minutes to 60 minutes. So whatever the insulin you give it, regular human insulin, your actropin, so that insulin is in the hexameric form. So that has to be converted to the effective therapeutic form as the monomeric. It takes a minimum period of 30 minutes to 60 minutes. So you have to give it the insulin at least 30 to 60 minutes prior to the food intake. And the duration, the peak action will be between the 2 to 3 hours. And the duration is about 4 to 6 hours, sometimes 7 to 8 hours. Suppose the NPH insulin. So this NPH insulin is a long-acting insulin. So it acts for about 12 to 14 hours. So onset of the action 2 to 3 hours. Peak action 6 to 7 hours. Duration, total duration about 12 to 14 hours. So this has to be given as a basal insulin. Maybe one shot at the bedtime to reduce the fasting hyperglycemia because it's a prolonged action. Rapid acting insulin analogs like your Lispro and Aspart. So they start immediately. Within the 5 to 10 minutes they start acting. The peak action is between 1 to 2 hours and the duration is about 3 to 4 hours. Ideally they are the good drugs. They are the good insulins to prescribe most of our people because our people they take a lot of rice. So immediately they start producing the sugars. And the maximum postprandial hyperglycemia between 1 to 2 hours. So this is the ideal insulins for most of our people is the rapid acting insulin analogs like Lispro and Aspart, which acts within the 5 to 10 minutes and the maximum action is between 1 to 2 hours. Premix insulins, your mixtards, your 30/70, etc. A combination of the regular insulin 30% and the rapid acting long acting insulin, NPH insulin is the 70%. So 30/70, 25/75, 50/50 they are available here. Long-acting insulin analogs like your Getamir or your Glargine, that is Lantus, or your Deglutec, so that is your Tresiba. So these 5 are the important insulins we are available in our armamentarium. You have the regular human insulin like Actropit. You have the NPH insulin like Insulatard. You have the rapid-acting insulin analogs like your Lispro, Novo Rapid, or the Fiasp, and you have the premix insulin like Novo Mix or your Novo or Mixtards. And long-acting insulin analogs like your Glargine or the Lantus or your Detimir or your Deglutec, that is the Tresiba. Okay, so these are the different insulins available in our places. So this is the very important chart showing how these actions starts. See, first you see the insulin, Lispro, Aspart, and the glucin. They are the short-acting or the rapid-acting insulin analogs. See what you mean by the analogs? You have the A chain and the B chain in the insulin molecule. The 21 amino acids A chain and 30 amino acids in the B chain. So in the B chain, at the 28 and the 29, you have the proline and the lysine. So just change these chains. That is your Lispro. Okay. So by changing these amino acids, you are getting the analog insulins. So analog insulins are very, very good insulins because they act very rapidly. See what happens to your regular insulin. So it takes a lot of that time. and then NPH insulin much more later. So detamir and the glargine. Insulin therapy has to be individualized. See, there are the different guidelines, but the treatment must be individualized. No convincing evidence for the superiority of the one insulin regimen over the another. Postprandial glucose values need a special attention in the pregnant diabetic women because in the GDM and in the pre-gestational diabetes, you see a lot of the postprandial hyperglycemia rather than the fasting hyperglycemia. Many women with the GDM have elevation of the single post-meal glucose levels. In such cases, a single dose of the regular insulin before the meal may suffice. So most of our people know that the fasting blood sugar will be 92 or 98 or maybe the less than the 100. Whereas the postprandial blood sugar, post-lunch, the blood sugar is 180 or the 200 or the 220. So there you can add one regular insulin before the breakfast or the before the lunch to tackle these cases. Here one case, they put on the 4 units of the rapid acting insulin before the breakfast and advised to monitor her blood sugars daily. She does well. After 2 weeks, her reports are as follows. She is compliant with the diet and exercise and also the insulin as you advised, 4 units before the breakfast. Now the fasting blood sugar is 118. 2 hours postprandial blood sugar is 126. So is your glycemic control adequate? No. Which one is no? Yes. So fasting blood sugar, there is a fasting hyperglycemia here, whereas the post-breakfast blood sugar is normal. Your target is 120, here 126, you need not increase the dose, 120. But 118, your target is 90. So there is about 28 milligrams more. So here you have to reduce the fasting hyperglycemia. So to reduce the fasting hyperglycemia, what insulins you have? You have the basal insulin. So you can use the NPH insulin in the poor population, or you can go for the basal insulins. Okay, long-acting insulins. So if the patient can afford, you can use the Lantus, maybe 5 units or the 6 units at the bedtime, or maybe the Tresibar, or your NPH insulin, maybe 5 units or 6 units or 10 units at the bedtime to reduce your fasting hyperglycemia. So your advice is continue the 4 units of your rapid acting insulin before the breakfast and add the NPH insulin or the glargine at the bedtime to tackle the fasting hyperglycemia. Okay. So the dose of the insulin is the trimester specific. Insulin doses need the individualization based on the carbohydrate content of the diet. So unfortunately, most of our diets, especially the rural India, so more and more rice. So more the carbohydrate, maybe 60%. Some people know they take 80 to 90% of the carbohydrate in their diet. So start with the low dose depending on the blood glucose levels. Always start with the low dose to avoid hypoglycemia. Suppose if the person gets an hypoglycemia, severe hypoglycemia, it is almost close to the death. If the family members, they do not recognize the severe hypoglycemia, unless you introduce a 25% dextrose, it is almost close to the death. So always avoid the hypoglycemia, especially the severe hypoglycemia. Always start low and go slow. So titrate frequently till the target levels are achieved. So suppose if the postprandial hyperglycemia is very high. So in this case, for example, the 2-hour postprandial blood glucose is 160. So what to do? So if the fasting 118, you have started the NPH insulin or your glargine. Fine. That's how you control the fasting hyperglycemia. Here the 2-hour postprandial blood sugar is 166. So what to do? She is getting 4 units of the post breakfast. Increase. So 4 units to how much? When the fasting blood sugar is 160. Sorry, 2 hours postprandial is 160. So 160 is very big. So what is the difference? 160 minus 120? 40. So the 40 you can't reach with the 2 units high. Yeah, you can go up to the 4 units or the 5 units or the 6 units. Suppose here the postprandial 2 hours postprandial blood sugar is 136. 136. So what to do? She is getting 4 units. 136. What is your target? 120. So what is the difference? 16. So you can reach with just 1 unit height. So just give the 5 units. Okay. So you can achieve your target. So depending on the difference between your blood sugar value and your target, you can up titrate the doses of the insulin accordingly. Okay. See, the occasional the insulin requirements may decline after the 30 weeks, 6 weeks due to the cessation of the placental growth. So whatever the insulins we up titrate, during the first trimester, second trimester, third trimester, we have to increase the doses of the insulins because of your hormones, your placental lactogen hormone or your estrogen or progesterone, etc. These are all insulinogenic hormones. They are all diabetogenic hormones. So they cause hyperglycemia. Okay. So after 36 weeks, there will be the requirement of the insulin has to be reduced. So this point you have to be in your mind. Suppose if the person is getting about 50 units insulin till the 36th week of the pregnancy, then after the 36th week of the pregnancy, she may require maybe 45 units, maybe the 40 units. Still you continue the 50 or 55 or 60, so you are inviting more and more hypoglycemia. So here another case study, a 24-year-old primate with type 1 diabetes on multiple daily insulin injections presents to your office for a follow-up visit. Her pre-breakfast 285, pre-dinner 10 95, and at 3 a.m. 68. So how will you treat her diabetes? It's a type 1 diabetes. She is getting almost the 4 shots a day, I think, because the type 1 diabetes with high blood sugars, we give basal bolus therapy. So basal bolus therapy means we give 1 shot of the basal insulin at the bedtime and 3 shots of the regular insulin before the breakfast, before the lunch, and before the dinner. So that is the most physiological way of giving the insulin to tackle your postprandial hyperglycemia. So after breakfast, there will be hyperglycemia. Give 1 shot of regular insulin before the breakfast to tackle the post-breakfast hyperglycemia. And after the lunch, again there will be the post-lunch hyperglycemia. Give 1 shot of the regular insulin before the lunch to tackle the post-lunch hyperglycemia. So the same thing happens to your dinner also. And at the bedtime, you give the basal insulin to tackle the basal hyperglycemia to reduce fasting hyperglycemia. Okay. So here, fasting blood sugar is 285. At 3 a.m., it is 68. And the pre-dinner, it is 95. So this is Somogyi phenomenon. So Somogyi phenomenon is getting the hypoglycemia at 3 a.m. So this 3 a.m. hypoglycemia is causing hyperglycemia at pre-breakfast. So post-hypoglycemic hyperglycemia. So what happens when the person gets the hypoglycemia at 3 a.m.? So the counter-regulatory hormones will raise. Your cortisol, your glucagon, growth hormone, epinephrine, norepinephrine. So these are all the counter-regulatory hormones they release immediately to tackle as a physiological phenomenon to tackle this hypoglycemia. So all these hormones will cause more and more blood sugar. So that is the reason fasting hyperglycemia is there. So what to do? So you have to reduce the basal insulin. You have to reduce your NPH insulin at the bedtime to reduce the fasting hyperglycemia. So in fact, if you don't check the blood sugar at 3 a.m., so what will you do with the fasting blood sugar at 285? You are further increasing the dose of the NPH insulin. So you are further causing the hypoglycemia at the 3 a.m. and the next day the blood sugar will be 300, postprandial blood sugar. So again you are increasing the NPH insulin or your basal insulin or the Lantus, and still you are getting more and more post fasting hyperglycemia. So this is the most practical point. So you have to think of the Somogyi phenomenon in such individuals, and here the answer is reduce the basal insulin, reduce the NPH insulin, and the person is not getting the hypoglycemia at the 3 a.m. and then don't cut the hyperglycemia at the pre-breakfast period. So this is the Somogyi phenomenon, how to deal it. In another case, a 32-year-old lady, type 2 diabetes of 6 years duration. She is on treatment with a combination of the glibenclamide and the metformin. She has recently learned that she is pregnant. Her lab reports fasting 80, postprandial 118, HbA1c 6.1. You advise her to switch over to the insulin, but she is not keen to change over to the insulin because she can't go to the Google. So Google says that fasting 80 is excellent. Postprandial 118 is also very excellent. And HbA1c 6.1 is too good. So why should I change the medication when the blood sugars are totally under control, under good control? So how would you tell her? So this is a case to say that to continue the same medications or switch over to the insulin. It's a tricky situation here because what the drug she is getting is not the teratogenic drugs. So metformin she can continue. So our MIG study metformin in gestational diabetes clearly showed that metformin is always safe. And even your glibenclamide in the Africa countries, they use the glibenclamide because it is the only sulfonylurea which does not cross the placental barrier. All the other sulfonylureas will cross the placental barrier and cause hypoglycemia in the fetus. But the glibenclamide doesn't cross the placental barrier, don't cause any harm to the fetus, and it reduces a good, very good drug which stimulate your beta cells to release more and more insulin in the mother to reduce the blood sugars. That is the reason her blood sugars are very good, with including HbA1c also. So here the two options are there. So to continue the glibenclamide or the metformin, or your book says that, or all the literature says that insulin is the drug of the choice during the pregnancy. So that's how we have to tackle this patient, whether to switch out the insulin or to stick on to the glibenclamide or the metformin. Oral anti-diabetic agents have been traditionally considered to be contraindicated in the pregnancy. That's the traditional approach. However, the recent evidence has prompted to relook at the role of some of these agents in the pregnancy, particularly the glibenclamide, urodionyl, metformin, and acarbose. So usually I don't advise the acarbose in the pregnancy period because acarbose, which mostly acts in the intestine level, it causes nausea, it causes vomiting, it causes the abdominal cramps because the localized action is in the intestines. But unfortunately, in the first trimester, most of these people will have the morning sickness. So I think acarbose is not an acceptable drug for most of our population. These three agents are classified as FDA category B drugs. These three drugs you can prescribe with caution. Here, 31-year-old Primey diagnosed with the diabetes during the 12th week of the pregnancy. She has been on metformin for polycystic ovarian disease for the past 4 years. Can metformin be continued during the pregnancy? If so, till what time? So what is your answer for the metformin continuation during the pregnancy? Yes or no? So yes. Till what time? So literature says first trimester is very, very safe. That during the first trimester it is very, very safe. Second trimester also safe. Third trimester is also safe. But first trimester very, very safe. Okay. So you can continue the metformin in the first trimester, and if the blood sugars are very high, then you can switch over to the insulin. So metformin is a begonite which acts as an insulin sensitizer. It's a beautiful drug, metformin, because in all the Indian population type 2 diabetes, this is the first drug to be prescribed unless otherwise contraindicated. So some of the people with metformin, they develop the gastrointestinal side effects, and in the presence of the renal failure, it is a contraindicated. It is the most widely prescribed anti-diabetic agent in the world, accepted as the first-line therapeutic agent for type 2 diabetes by both national and international diabetic organizations. Some women in the reproductive age group may be on metformin for your PCOD. First studies on the use of the metformin in pregnancy were conducted in the 70s, showed no difference in the perinatal mortality rates compared to the insulin. Later studies raised the concern regarding the increased incidence of the preeclampsia in women using the metformin. So, some chances of having more and more preeclampsia. This is the MIG study, metformin in gestational diabetes study. 751 women with GDM, 20 to 30 weeks of the gestation to receive the metformin with supplemental insulin if required. Still the blood sugars are very high in spite of the metformin therapy, then you can add the insulin also. So primary outcome, a neonatal hypoglycemia, respiratory distress, need for phototherapy, birth trauma, 5-minute Apgar score less than the 7 or the prematurity. The results, 92% of the women continued the metformin to the term. 46 needed the supplemental insulin. No significant difference in primary composite outcome between the groups. So no differences between your insulin therapy or your metformin therapy. No serious adverse events with the metformin. And women preferred metformin to the insulin because it's a oral form. So the possible concerns, the placental transfer of 10 to 16% of the neonatal hypoglycemia. Currently, metformin is not accepted as the first-line pharmacotherapy for the GDM, as per the books are concerned. Women on metformin for PCOD can continue that drug. Now, move on to the glibenclamide. See the second generation sulfonylurea. long half-life, can be given once or twice daily. Usually we give once a day. Dosage 2.5 to 20 milligrams per day. Usually we use the maximum dose is the 10 milligrams, because all the sulfonylureas we use the 50% of the maximum tolerated dose. Unlike other sulfonylureas, this does not cross the placental barrier, probably due to the high degree of the protein binding. Hence, the fatal exposure is very, very minimal. So, more evidence is needed before the glibenclamide can be recommended as a first-line agent for the diabetes in pregnancy. Whereas our area is concerned, we prefer metformin, and we don't give the glibenclamide in our GDM population or your pre-gestational diabetes. Straight away after the metformin, we go to the insulin therapy only. So, our favorite drugs are metformin and the insulin, not the glibenclamide. Other anti-diabetic agents, there is not enough evidence for safety and efficacy of the agents such as the thiazolidinediols, D4 inhibitors or GLP analogs in the pregnancy. So, dear PGs, patient education is very, very important. See, that's what our Professor Jocelyn told. So, he was the father of the diabetology. He once told that the one who knows the diabetes most lives longest. So, that is the importance of the medical education. So, the essential for ensuring the optimal outcomes encourages the pregnant woman to take charge of her own health and the well-being. Most pregnant women want the best for their unborn babies. Education provides them the tools to achieve this goal. So, education is very, very important. So, I have to spend some time with the GDM mothers about everything about these outcomes and etc. So, what are the components of your patient education? The basic knowledge of the diabetes and the DCD. You have to tell the targets. Okay, importance of the regular follow-up, importance of the compliance with the diet and exercise and the medications like your metformin or the insulin storage and the administration techniques, sick day rules, what to do in case of the hypoglycemia. So hypoglycemia awareness, what are all the symptoms of the hypoglycemia, how to detect the hypoglycemia at the home, importance of the retesting the glucose after the delivery. So because these are the future to a type 2 diabetics. So you have to tell them after the 6 weeks of the delivery, so they have to go for the OGTT to rule out the continuation of the pregnancy, after continuation of the diabetes is there or not. So the first visit is 6 weeks, second one is 6 months, and the third one is every year. That is the post-pregnancy diary. How to prevent the future diabetes in the self and the offspring. So about the reduction of the gained body weight during the pregnancy and then the complex sugars, etc. So this is very, very important to avoid the or to postpone the future type 2 diabetes. Otherwise, the most of our Indian GDM population, they get the type 2 diabetes within the 5 to 10 years of the delivery. So we have to postpone the onset of the type 2 diabetes in these individuals with a good dietary approach and the good exercise approach. So monitoring the GDM is very, very important, and monitoring the pre-existing diabetes is much more important. So self-monitoring of the blood glucose with your glucometer. So HbA1c is also a role because the index HbA1c is very high at the time of the pregnancy, say 9 at the 10. So you're getting more and more complications. So serum fructosamine or the glycated albumin, that is the HbA1c is the average blood sugar in 3 months because that depends on your RBC lifespan. Whereas your fructosamine, the average blood sugar of 15 days duration. So this is much more important in your pregnancy HbA1c rather than your fructosamine. Fructosamine is more superior long-term estimation in the pregnancy because pregnancy is a very short duration. Maybe the second half of the pregnancy means GDM maximum 2 to 3 months only. So continuous glucose monitoring system, so CGMS, that is also ideal in type 1 diabetes with retinopathy, with nephropathy, with vasculopathy, etc. in high risk individuals. Sometimes now we put the insulin pumps also in them. So this is the one case study. GDM and is on 8 units of the NPH insulin at the bedtime. She is getting 8 units of the NPH insulin at bedtime. In addition to the rapidly acting insulin before the breakfast. She complains of excess hunger during the early hours of the morning. Her reports are as follows. Fasting 61, after breakfast 102, before lunch 90, after lunch 112, before dinner 91, after dinner 107, at 3 a.m. 58. So are these values are acceptable? No. So why she is getting hunger during the early hours of the morning? Hypoglycemia. So 3 a.m. it is 58 and 6 fasting also 61. So how much she is getting NPH insulin? 8 units. So do you want to increase the 8 units or reduce the 8 units? Yes, you are absolutely right. So this 8 units is causing hypoglycemia. So you have to reduce the 8 units to 6 units or the 5 units. So this case, 10 units of the NPH insulin at bedtime, in addition to the 8 units of the rapid acting insulin before the breakfast. So before the breakfast, getting 8 units. At bedtime, getting the 10 units of the NPH. She is compliant with the diet and exercise prescription, what you advised here. Here are the reports. Fasting 88. Are you happy? Yes. After breakfast 115. Okay. Before lunch 95. Okay. After lunch 162. Not okay. Before dinner 100. Good. After dinner 105. Good. 3 a.m. 79 is good. So the only value abnormal here is after lunch. So how to tackle this? Add. Already before breakfast she is getting 8 units. Okay. If you increase the 8 units before breakfast to 10 units, what will happen to the before lunch blood sugar? She will get hypoglycemia. So that will not tackle the post lunch hyperglycemia. So give another shot of short acting insulin. So continue the 8 units before the breakfast and just give 4 units or the 5 units before the lunch. And continue the 10 units NPH insulin because the fasting is normal. 3 am is also the normal. So it's very good. So another case, you are reducing the NPH because of the fasting hypoglycemia. Here you are adding another regular insulin, rapid acting insulin before the lunch to tackle the post lunch hyperglycemia. Okay. This case, 14 units of the NPH insulin at the bedtime, 12 units of the rapid acting insulin before the breakfast. So before the breakfast 12 units and at NPH insulin 14 units. See the values. Fasting 86. Happy? Good. After breakfast 91. Good. Your target is 120. 91 is okay. Before lunch 62. So you are inviting more hypoglycemia. After lunch 100. Okay, good. Before dinner 81. Good. After dinner 101. Very good. At 3 am 81. So what is abnormal here? Pre-lunch is abnormal. Pre-lunch is abnormal 62. So how to reduce pre-lunch hypoglycemia? So are these values acceptable? Except pre-lunch, all are acceptable. What is the next line of management? So 14 units of NPH insulin bedtime. Let us continue. Okay. 12 units of regular insulin before breakfast, causing hypoglycemia before lunch. Okay. So what to do with the 12 units? Reduce. Reduce to maybe 8 units or 10 units. Am I clear? Okay. So now the acute metabolic complications of the diabetic pregnancy. So acute complications are two. One is hypoglycemia. The second one is DKA. So this hypoglycemia is a very common. So these are all the symptomatology. Your adrenergic hypoglycemia. You know all the symptoms of hypoglycemia. Palpitations, sweating, headache, restlessness, sometimes unconsciousness, froth in the mouth, convulsions. So depending on the amount of the hypoglycemia. Suppose if the person's blood sugar is 50, so they are totally conscious with some symptoms. When the blood sugar is 20 or 24 or 30, so they lose the consciousness. When their blood sugar is at 15 or the 20, so they develop the convulsions. So it all depends on these values. Effects on the fetus, hypoglycemia. It can adversely but reversibly affect the fetal heart function. It is shown to be associated with an increase in the small for the gestational age babies. It can possibly affect the postnatal beta cell function also. So we have to avoid the hypoglycemia. All the hypoglycemia is always dangerous. Here a good case, a 30-year-old second gravida with type 1 diabetes of 12 years duration presents to the emergency room during the 36th week of the gestation with complaints of persistent vomitings and diminished fetal movements. She is type 1 diabetic, 36th week pregnancy, your casualty or your emergency room with diminished fetal movements and vomitings. She admits skipping her last 2 doses of the insulin due to vomiting and poor oral intake. She has been irregular with her antenatal visits, and her sugars have been unsatisfactory all through the pregnancy. Her previous blood sugar values are always abnormal values, and follow-up, very poor follow-up. On examination, she is tachypneic, hyperventilating, tachycardia, and dehydrated. Fetal heart sounds were absent. There were no obvious foci of the infections. What is the most likely diagnosis? Diabetic ketoacidosis. Diabetic ketoacidosis. What investigations would be helpful? Urine ketone bodies, and then electrolytes, blood sugars. Okay, so they are very, very important. See, the blood sugar is 246. See, in pregnancy, you need not get the 300, 400 to cause the DKA, unlike a non-pregnant woman. Even a minimal elevation of the blood sugar also can cause the DKA. Here the sodium 142, so potassium 3.3, chloride 100, bicarbonate 10, urea 61, creatinine 1.3. So renal azotemia is also here. pH 7.1, your acidosis here. Urine keto body is 3 plus, your ketosis. So acidosis, ketosis, renal azotemia, and hyperglycemia. So DKA, these diabetes, here the blood sugar is very high. K is ketosis, your ketone bodies are positive here. A is acidosis, your pH is less than 7.4. So all the three are there to call it as DKA. So the management, the fluid management is very important. Insulin is very, very important. Electrolyte replacement is very important. So in DKA, what is the treatment of the choice? First choice is the fluids or the insulin? Fluids. That is the reason we have written as the fluid management as the initial agent. So don't aim for the euglycemia immediately. So please check the hydration part. So the dehydration has to be corrected immediately. So 1 to 2 isotonic saline in the first hour. Don't use the RL. Don't use the DNS. Always use NS only. Normal saline. Normal saline. So 300 to 500 ml per hour. Not 50 to 160 ml per hour. Here more and more. Maybe 500 ml per hour. Okay. On 0.9%. That is your normal saline. Or maybe the half normal saline also we use it when your sodium is very high. Add 5% dextrose when the serum glucose approaches your 200. Otherwise, these people will go into the cerebral edema, DKA. Of course, the insulin you have to use the regular insulin, not subcutaneous in DKA. Always use intravenous only. Don't use the premix insulin. Don't use the long-acting insulin. Only use the regular insulin. Always intravenous. So this case, a 33-year-old lady with a type 2 diabetes of 4 years duration. Hypertension for 3 years. Well controlled on telmisartan and amlodipine, Telma AM. She is now planning to conceive. What changes would you make to her medications? Excellent. She is getting ACE inhibitor ARB. ARB she is getting telmisartan. That is contraindicated during the pregnancy. So it has to be stopped. So continue the amlodipine. Or you can add the alpha blocker. Or you can use the labetalol. Or you can use the alpha methyl dopa, etc. Don't use ACE or ARB or diuretics here. What should you look for your during the pregnancy? What are the blood pressure targets for her? Always 120/80 or less than that also. Otherwise, no, these people will go into the eclampsia. So you are all familiar with obstetric management. So I will skip these obstetric management slides. Antenatal visits are very, very important. Monitoring the fetal growth and the well-being, and timing and mode of the delivery. So this is very, very important. So too early, these people will have RTS and prematurity, timing of the delivery. Or late, so late IUFD and macrosomia. So it should not be too early or the late. Gestational specific risk for the stillbirth continues to fall up to 38 weeks and increase slightly in the post-date pregnancies. In women on insulin, most would plan delivery at 38 completed weeks. In diet control diabetes, aim to deliver at the 40 weeks. So somewhere after 38 weeks, you can plan for the delivery. That is the ideal time. Steroids to reduce your respiratory distress syndrome. Here 33-year-old lady presents in the 38 weeks of the gestation. She has had 3 prior uncomplicated vaginal deliveries. Estimated fetal weight at this time is 4.6 kgs. So how would you counsel her about the delivery? After extensive counseling, the couple declined the elective cesarean section delivery. So how should be managed at this point? So vaginal delivery is the safe in GDM. No contraindication to the vaginal delivery. Induction of labor is a safe option. Previous obstetric history. CS only for the obstetric indications, not for the diabetes indication. Okay. So cesarean section in a GDM is only for your obstetric indications. So being a diabetic is not an indication for the sections. Be prepared for shoulder dystocia on the pitch. Intrapartum management is also important. Need to maintain the glycemic control. Here again, you have to give the intravenous insulin only, not the subcutaneous insulin. Both the antepartum and intrapartum hyperglycemia increases the risk of the adverse neonatal metabolic outcomes, like your hypoglycemia, etc. Good intrapartum glycemic control reduces the risk of the fetal acidosis and also the neonatal hypoglycemia. So insulin requirements usually decreases during the labor. The work of the labor requires energy. Oral calorie intake is typically reduced. So the main objectives are to maintain the normal glycemic values, maintain the adequate hydration, and ensure the adequate calorie intake. Immediate postpartum management. A pediatrician skilled in neonatal resuscitation should be present. Clamp the cord early to prevent the polycythemia. Vitals and Apgar score. Keep the neonate warm and transfer to the incubator. Preliminary physical exam to detect the malformations. Monitor the heart rate, respiratory rate. Monitor the activity for at least 24 hours after the birth. Promote the early breastfeeding. So these are very important. Mother's glycemic status. Recurrence. 1/3 of the women have a risk of the recurrence. So the common risk factor for the GDM is past history of the GDM. So risk is higher in the older women, more than the 30 years of the age, more paras, multipara, and also the more obese and higher interpregnancy weight gain. So your interpretation of the OGTT, follow-up care. So here a 34-year-old second gravida, GDM at 27 weeks of the gestation and put on the insulin therapy. Following the delivery, blood glucose levels normalized and she was able to stop the insulin. After 6 weeks, she underwent an OGTT with 75 grams glucose. The results are as follows. Fasting 82, postprandial 126. What is the diagnosis? Normal or abnormal? So normal. What is the risk of developing the diabetes in the future? No risk or more risk? More risk because it's the history of the GDM. So at 6 weeks they are normal. So you have to advise after 6 months also. And then the yearly ones. So during the lactation, so this is also very important. Insulin remains the treatment of the choice during the lactation. So glibenclamide should not be given because it crosses the breast milk. Follow-up care and the long-term consideration is very important. Risk of the future type 2 diabetes, risk of the GDM in the subsequent pregnancies, and contraception is very, very important. A 40-year-old lady has a fasting blood glucose of 154 in her annual checkups. She gives history of the GDM during her second pregnancy 6 years ago, following which she was delivered a healthy 4.2 kg baby by CS. She has not checked her blood glucose level since until the present visit. A routine Godavari mother. What is the diagnosis? What is the next step? So 40-year-old lady, fasting blood sugar 154. Type 2 diabetes. Type 2 diabetes. What is the reason for this type 2 diabetes? History of the GDM. So risk of the future diabetes. Women who have had GDM are at high risk of developing the type 2 diabetes in the future. So the rate of conversion varies from 35% to 60% over the 10 years. So my gut feeling is maybe 100% over the 10 years. All our GDM mothers. Almost 80 to 90% less than the 5 years. So risk of the future diabetes is very high. So risk factors, overweight, obesity, and high ethnic group, because all Indians are high risk, strong family history, etc. So prevention, weight loss, regular exercise, possibly medications. As a preventive drug also you can prescribe the metformin as a diabetic prevention programs. Management of the additional cardiovascular risk factors. Contraception is very, very important. So IUCD is very important here. Therefore, effective management and follow-up of the GDM can prevent the type 2 diabetes across the generations. So what are the take-home messages? Women with the pre-existing diabetes should attain the optimal glycemic targets prior to the conception. That is a very, very important. In women with the GDM, MNT is the first line of the management. Okay, medical nutrition. Don't underestimate the value of the medical nutrition. If glycemic targets are not achieved the MNT, then you can start with the metformin. Then the insulin is the treatment of the choice. Pregnant women with the diabetes should perform the frequent SMBCs and adjust the therapy accordingly. More frequent and intensive obstetric monitoring is very much needed. Timing and mode of the delivery is dictated mainly by the obstetric outcomes. Following the delivery, most GDMs can stop the insulin, but they should go on the follow-up. They need a follow-up after 6 weeks, after 6 months, and every year for the development of type 2 diabetes. So that finishes my talk, and I have the few questions. You please answer these questions. For women with pre-existing type 1 diabetes, the usual dose of insulin in the first trimester. What is the first trimester? 0.5 or 0.7? 0.7. A woman with GDM is found to require the insulin therapy. Okay. She has fasting and PP 158. What would be the ideal regimen for the insulin initiation? A single shot of the bedtime NPH insulin. Here the fasting is normal. Say fasting is 98. Here the PP is 158. What is your answer here? Fast. A single shot of regular insulin before the breakfast is the right answer. Women with the GDM started at 6 units of the regular insulin before the breakfast. 2 weeks later, fasting is 82 and postpone is 122 respectively. But here after lunch, 161. What is the next line of management? A is Amlapuram. Okay, you had a second shot of regular insulin before the lunch is the right answer. A pregnant woman with GDM, 8 units of the NPH insulin at bedtime, 6 units of the regular insulin before the breakfast. She complains of recurrent low sugar symptoms in the early hours of the day. Which of the following steps can be expected? So she's getting hypoglycemia in the morning hours. She's getting 8 units of the NPH insulin. Endure the regular bedtime snack. Reducing the dose of the NPH insulin. Switching over from the NPH to the long-acting insulin analogs. All of the above. D is the right answer. Delhi is the right answer here. Because enduring the regular bedtime snacking to control the fasting hypoglycemia, reduce the dose of the NPH, or you can convert the NPH into the Glargine or the Lantus because they are the peakless insulins. So the hypoglycemia risk is very low with the basal insulins like your Lantus and the Trispa, whereas the NPH insulin will have the peak. Which of the following is the most appropriate method of monitoring the glycemic control in pregnancy? Bombay, not A1C. In pregnancy, fructosamine, CGM or SMBG. SMBG is the right answer. Delhi is the right answer, and then the fructosamine is the right answer. Regarding HbA1c in the pregnancy, all are true except It is often spuriously reduced in pregnancy secondary to the iron deficiency. In iron deficiency anemia, it is spuriously increased, not reduced. Okay. B is right. Useful in early pregnancy to differentiate the GDM from the pre-existing diabetes. Okay. It may help in predicting the risk of the congenital malformations. So more the A1C, more the congenital malformation. And also the predicts the adverse maternal outcomes. So the more A1C, the bad outcomes. Which of the following fetal biometric markers can be used to assess the adequacy of the glycemic control in the mother? Again, Amalapuram, abdominal circumference. All of the following agents can be used to treat the hypertension in pregnancy, except enalapril is ACE inhibitor, contraindicated. Nibudifan is the calcium channel blocker, continue. Labetalol is alpha and beta blocker, continue. Methyl-dopa, earlier it was the drug of choice. Don't use the enalapril. Insulin requirements during pregnancy continue to increase until 36 weeks of the pregnancy. After that, because of the placental insufficiency, they reduce it. In patients on insulin, the delivery is the best carried out at 38 weeks of the pregnancy. All women with GDM should undergo OGTT. Bombay, 6 weeks. Which of the following is the risk factor for the development of type 2 diabetes after GDM? So Delhi is the right answer. Obesity is the risk, family is the risk, and need for insulin in the pregnancy. That means more and more gestational diabetes, higher severity. So they are more prone for the GDM or type 2 diabetes at that time. Which is the contraceptive method of choice for women with poorly controlled type 1 diabetes? IUCD is the right answer. Regarding the intrapartum management of the hyperglycemia, all the following statements are true except most women with GDM will not require insulin during delivery. In women with insulin requiring type 1 or the type 2 diabetes, the subcutaneous long-acting insulin should be continued throughout the labor. Subcutaneous during the labor, insulin. IV insulin infusion is the best mode of insulin delivery during the labor. CSSI is another valuable therapeutic option. So continuous subcutaneous insulin infusion. Okay. So the wrong answer here is Bombay, B. So that finishes with. Thank you very much for your patient evening.